Hi everybody, my name is Gareth Tudor-Williams. So I'm here in two capacities. Firstly, because I am representing the infectious diseases team, so I'm one of the consultants on the paediatric infectious disease team. And secondly, because I'm also very involved in the undergraduate programme for paediatrics in the 5th year. So I'm looking forward to all of you guys arriving and really hitting the ground running, because I think it's absolutely fantastic that you're all here on a Tuesday evening so late, and it's brilliant. And I'm absolutely sure that this is going to set you up for being able to really enjoy paediatrics in a way that a lot of the students who arrive in the 5th year at the moment are pretty daunted for the first week or two, just that whole business of interacting with children. And so I'm very, very keen that we do extend the programme. Everything I've been hearing about it has been very positive. And the fact that you're here this evening and that we're talking about moving into some of the most tricky areas of paediatrics is terrific, and I'm very, very strongly supportive. And of course, Nancy and Josu and their team are looking after some of the sickest children for a period of time that we have out on the wards, short of the intensive care unit. These are the most vulnerable children. But if you think about it, you've already heard that we've chosen this ward to look after kids with infectious diseases and those with absolutely ablated immunity. Children with the most profound immunosuppression that you can imagine. Now, why on earth have we done that? I mean, Nancy's alluded to it a little bit, but why do you think we've got kids who have potentially communicable diseases, multi-drug resistant TB or HIV infection and other complications under my care in the ward, alongside kids who've just undergone bone marrow transplantation, all in one ward space? Why would we do that? Is it because we basically haven't got enough space? I mean, what would be a better way of doing it? Separate them out? Yeah? So have the kids with infectious diseases in a completely different part of the floor and the kids with severely impaired immunity in another space? I'm really interested. Can I see a show of hands? I mean, who agrees with that? Because it does make good sense. Who agrees with it? So the only reason that we're not doing it is because we're too bloody cheap, that we haven't got the funds to. So let me put this to you. If we had an HIV-infected child who was newly diagnosed, and this happened last summer, 7-year-old child from outside London, hadn't been picked up through the perinatal assessments and so on, and turned out to be HIV-infected with an absolutely obliterated CD4 count. The CD4 count was about 10, absolute count. And she had catastrophic cryptosporidial diarrhea. So what do? We take a chainsaw and chop her in half and put the infectious bit over there and the immune suppressed bit over here? It doesn't work, does it? And the reason is that actually infectious diseases and host defence go absolutely hand in hand. And Josu has already said the children under his care with impaired immunity are very troubled by infection. And so, of course, it may be difficult to diagnose, it may be opportunistic infection, it may be infection that isn't going to affect you if your immune system is fine, that the kids are suffering from, but nevertheless, it is potentially communicable and can come from one cubicle to another if we're not really professional. So that is my message to you, that you are totally welcome on Grand Union. I'm very keen that those of you who feel that you want to commit to spending that time with one transplant patient should be able to do so. But I'm also keen that those of you who don't necessarily want that and you just want to rock up and see who needs a bit of Gemma's kind of attention, children under our care are often on that ward for quite a long time. We've had a number of kids with really nasty empyemas, with the kids with TB, with other causes that end up with osteomyelitis, end up on that ward for really extended periods. They need your help really every bit as much as the BMT patients. It'll be a different relationship. They probably won't be in hospital for quite the same length of time, but sometimes it's unpredictable, and some of our youngsters have been there for much longer than we would wish, necessarily. So, there's lots of opportunities for you to get involved and to get to know some of the kids with very different things that are going on. The history of the ward is quite interesting, and I'll just take 2 seconds to help explain it, because it's weird. When you go on there, you'll see that there's a row of cubicles that run along the corridor internally, And then there's another batch of cubicles on the outside. And when I first came here, which was a long time ago, that was an asphalted outside play area. But it was north-facing, it was dark, nobody ever played out there, and we desperately needed the space. Because when I first arrived back in the mid-90s, we were looking after one of the largest cohorts of HIV-infected adults and children in Western Europe. And we had adults and sick children needing hospital care at the same time. And we got a lot of money from the Elton John AIDS Foundation to build that suite of rooms at the far, on the outside wall of the ward. So the internal ward, if you look at it, the windows are actually the outside windows of the hospital, but they're now internalised by this suite of rooms that we could nurse sick adults and their sick children at the same time. It was revolutionary. It was felt to be, the best model of care for HIV-infected people. And by the end of the 1990s, we didn't need it. Why not? Why do you think we actually didn't need the inpatient facility anymore? Because, as you will soon see in clinical medicine, HIV has been totally transformed by antiretroviral therapy. And these people who were needing hospital care and were dying are now out there getting on with their lives. And that's true for most of the population. The kids that we look after, they are surviving. They're going to school, they're heading to uni, and they are not going to be on the wards for the most part. But nevertheless, there will be sensitive things that you have to deal with, and information that you hear that maybe the young person themselves, not all of the children know their diagnosis if they're HIV infected, for instance. So there will be sensitive stuff that's going on that you do need to be quite mature about handling, and obviously taking a cue from whoever it is, the nurse or the doctors that you talk to, so that you don't disclose stuff that is inappropriate. So, if your focus is on making it as normal as possible, and your interaction with them is at that level, because that's actually what's going to really help you in terms of your confidence in interacting with kids later on. And keep it, as Gemma says, down to the level of an interaction that is fun and really helps them feel like you're a friend and you're not likely to stick a needle in them or talk about stuff that's very difficult. Because I think it can be very light-hearted. And, obviously, some of the children are going to want to talk to you and disclose stuff that's worrying them, and that's fine. You can be a listening ear. But I just want you to be pretty careful about what you are saying to them, especially where it's kind of sensitive information that you may have picked up from handovers or from the medical notes or whatever. I'd encourage you probably not even to look at the medical notes. I don't know what you feel, but that isn't the focus of your interaction at all. And I don't want you to get bogged down in the medicine. We'll teach you all that in the 5th year. So, any questions? I really hope that you will be able to interact with the ID patients as much as the longer term ID patients. Yeah?
How many ID patients do you have?
Well, it depends how many haematology patients are cluttering up the wall. No, no, we have a wonderful working relationship, and the reality is that at any given moment there may be a predominance of haematology patients, there may be a predominance of ID patients. I would say over the last year, actually, you've probably had 2/3 of the beds, and we've had 1/3.
It comes up under some different we set the rooms and everything. So.
Yeah. But of course, actually the other thing that
but
you
actually
shouldn't...
it's only 4 active transplants, so all the patients who are there, whether post-transplant or they have all the hematological conditions, are like ID patients. You can see them in the same once in every 2 weeks situation. So you have these 14 rooms, so 4 of them active transplants, the other 10 you can treat them.
All sorts of stuff. And in fact, some general paediatrics comes through because we've got the lion's share of the cubicles across the floor. So, kids who are coming in with bronchiolitis and so on may end up in our cubicles as well. So it's by no means, it's an enormous mixture and a lovely challenge for you. Lots of different diagnoses coming through the door. And of course, under Josu's care, there'll be kids who are, undergoing cancer therapy for leukemias and some solid tumours, and they come in with febrile neutropenia, with fevers and low counts, and of course the sicklers as well. And some of the sickle cell patients can have a prolonged stay as well, can't they?
One thing I forgot to say, don't think any of us have mentioned. There is a couple of drugs which are nebulized that we use with these patients, whether ID or hematology, whom, if you are exposed to them, can have teratogenic effects, can damage a child born from you if you are about to get pregnant, around that period of time. So sometimes you will see that it's very clearly marked, don't enter into a room. Don't enter, okay? Unless you don't care about it. Because that is the reason. You will see all these cubicles at some point may be closed with a special sign not to enter. That is because they are receiving medicines which could be harmful to you. Once the medicine is finished and everything is wiped out and clean, it's fine. Nothing happens.
And just in a similar vein, you mentioned about patients with MDR-TB, for instance. Do you have any reservations with any of us going?
Look, you're all going to be professionals, you're all training to be doctors, and I think that provided you are following the advice, the kids with respiratory pathogens that are likely to be harmful to us, we wear respiratory particulate mask appropriate to the level of risk, and quite obviously we wouldn't let you in there without a very clear demonstration of how that should be done.
Just to clarify, MDR-TB for the first and second years who might not know, multi-drug resistant TB, just to clarify that.
Yeah.
I think if you always ask the nurses, can I go into that room? Before you go in, there shouldn't be any reason to give you that.
Yeah, but obviously we'll demonstrate everything and make sure you're completely comfortable with how to protect yourselves. Yeah.
On Great Western and so on, we were told we're never meant to be alone with the kids. So how does that work on those wards where we are allowed to be alone in the rooms?
That was for safeguarding issues and to protect, they were always put in pairs and kind of they would leave the door slightly open or their partner would know where they are, but obviously it would be different on that ward.
Well, yeah, you're not going to be popular if you leave the doors open.
Yeah, exactly.
So we are going to have to give a little bit of thought to that. I mean, I think there's no problem at all in going in pairs in terms of the play activities.
If we made a provision that at least the team leader was to know which kid they were going to spend their time with on the day, would that be?
I mean, I can see for your patients that you'd like
most
to limit the
numbers. Most of the transplant
patients
have the parents inside of the room.
Okay.
Yeah.
So
from a safeguarding point of view, that takes care of it, really. But for the other children, I think there's no... I mean, some of the cubicles are a bit small, but yeah, still there's plenty of room for two of you to be there. And I would use the same ground rules that you do for Great Western.
If there is a real commitment from you guys that you really are able to provide an intensive but short period of time, then we might be able to think about having pairs in the rooms, provided that we can show that it's going to be the same people all the time and we are not going to introduce many people in and out. So it's
Nancy, can I just ask, I mean, most of your transplant cubicles have actually got cameras.
We've got cameras in.
Yeah.
Four cameras, so so in actual fact there is from that, but you have CRB checking before you come on, aren't you? So from a legal perspective, then there shouldn't be an issue, and so although there's shouldn't tell you that, but there's no tape. We don't actually tape.
we went from tomorrow.
Let's put that out. But it's
But it's being watched.
I mean, to be honest, most of the parents, until they really got to know you, they wouldn't want to leave anyway. So,
yeah.
Sorry, quite a simple question. So the rest of the 6 of them?
Well, there are four patients who are having the actual transplant. Those 6 weeks where they receive the chemotherapy, the bone marrow cells, and then we wait until the blood is produced. In addition to that, there will be children who have had transplants within the last 6 months and get admitted with complications. There will be children who don't produce blood or have other hematological conditions who are also being treated there, and there will be children who have infectious diseases complications.
Does that answer the question?
Yeah.
Okay. Okay. Well, I just like to echo what you said about never being alone. I mean, you are. There's a, these are pretty sick kids some of the time, and we're not going to send you into a room where we think that child is on the edge of having to be transferred to the intensive care unit. I mean, again, we will choose patients for you that we know that you can handle. I mean, there's no point in sending you into rooms where the children are so sick that there's not a hope that you can engage them in play.
I think what's also very important is, and it's not to put you off, is that with some of our children as well, they do get quite, obviously they're bored, they also get quite depressed at times as well, and one of the ways that kids show their depression is they will withdraw into themselves and turn their back on you. And sometimes, as Gemma says, it's quite an art to know whether actually is that a sign to back off, or is that a sign of actually carry on, but I'm just going to not pay attention to you. And a lot of the time it's quite a good idea you will sort of ask advice, basically. We've got a psychologist, ask Gemma about what she would do, and a lot of the time it's just sit down and talk to the parent. And the child's listening and they are getting stimulation from it. And it could be that you read them a story if that's what they want. And so it's all part of it, so don't be put off by it. But we all go through that of actually sort of thinking that the child is basically withdrawing or neglecting us, and that can put us off from actually going in. And they're the ones that really need us. So that's a really good learning point.
Okay.
Anyone got any more questions for any of the members of staff who have kindly joined us today? No? Okay, so I'm going to do a bit of a summary and bits and pieces which I have to go through. Probably, if they have any other questions, would it be possible for them to contact you guys?
Well,
or
feed it
contact
through you.
me?
Yeah, feed it through you.
Yeah, so if you guys have any questions, because I know that from the last training day, you felt comfortable, but a few of you are still a bit worried about going on to wards. So if you have any worries at all about starting on Grand Union, please do let us know and we can pass on any questions and answer them as best we can. Yeah?
Well, it's fair to say it would be good if you're going to do Grand Union if you have done Great Western at least once before.
Most of the students here are all previous volunteers. There's a couple who are on the waiting list, but we'll make sure that they've had their experience there first.
Can I just mention we've got one colleague here from New Zealand, and I suggested she came because I thought that this would, you could spread this idea across the other side of the world, and maybe if you can get together afterwards with the team leaders here, I think that'd be really worthwhile. Sorry to embarrass you.
Okay. Are there many Arabic speakers here?